Good morning, everyone. Today we have the pleasure to have a very interesting talk by our dear audiology team at Cochlear Hospital. It will be the implant program, and it will be presented by Hlomi Jack. Over to you.
Thank you so much, Divya. Yes, I am indeed not alone. Good morning to everyone. I think I should rather greet. I am here with the rest of the team. I hope you can see all of us. Sharon to my left, who's our HOD. And then I have Yonela and Zain, who are part of the audiology team, and Melanie, who holds the fort and makes sure that everything is in order for us with bookings and so on and so forth. So let me get right back into it. Thank you for giving us the opportunity to present this morning for our Cochlear Implant program. This idea to use your multidisciplinary and educational platform to discuss our protocols and candidacy criteria came about whilst we were refining this program. So I know that you may expect that we just touch on cochlear implants. However, we've decided to include both the cochlear implant and the bone-anchored hearing devices that we use. It also came about because we wanted to ensure that we're not only in refining the program and ensuring that we're using appropriate guidelines whilst selecting appropriate candidates, but also because the selection of those candidates needs to be more intentional for us. And which better way than to make sure that a multidisciplinary team is also presented to and included. So to us, for instance, one of the most important things in selecting candidates is to ensure that once they've been selected, they have a better chance at having really successful outcomes with their devices. So successful outcomes basically would look like full-time use of a device, an improved quality of life for the patient, and better access to educational and employment opportunities. And of course, to ensure that the program is more sustainable. So as you see throughout, we'll touch on the history of the program, how far we've come, our challenges right at the beginning. Let me go on. I'm just trying to move to my next slide. Great. So the objectives of this presentation is, as you know, we want to discuss protocols, but first we'll touch on the vision and the mission statement of the GSH implant program. We also want to discuss our core values, what anchors us and what allows us to do what's right for the patient. And then we'll get into the protocols and the referral and candidacy criteria. Right at the end, I've also included just a case discussion where we can have a bit of an interactive session on a patient we have been referred, and I'd like to just get us to think about using these protocols and knowing the candidacy criteria, how we would manage this patient going forward. Okay, great. So as I've said, we are guided by a vision, and that is to provide implantable devices and a quality, comprehensive, and transparent service to patients who have hearing impairments and do not receive any benefit from conventional hearing aids. How we do this, we want to ensure that we carry out timeous and appropriate assessments and counseling, and that speaks to the protocols that we have followed. And these protocols aren't protocols that we pretty much, dreamt up or thought that we should use, but we are guided by the South African and international standards, and obviously by the colleagues in this field who have been doing it for many more years than we have. So we borrow from what is already existing and we refine it to actually fit our context and the patients that we see and the population that we serve. Just to give you a bit of a background in terms of trends, when the implant program started, it only consisted of bone-anchored hearing devices. And that started back in May 2011, where the first implant took place, here with Dr. Maya and Sharon Pithi and the rest of the audiology team at that time. Some of us were pretty much still in varsity at that time, and who would have thought that we would also go on to at least be part of something that is this great and where we can get to help patients and learn this kind of skill later on in our careers. Since 2011, the Bone Anchored Hearing Clinic has implanted 40 patients. Of these 40 patients, 4 have been extracted. Now that could be due to various reasons. It could have been infections. Most of the time that is typically what led to the abutments being extracted. Or in other cases, patients have just simply decided they no longer want to use the device and they request for the abutment to be extracted. 3 abutments fell out, also due to infection. And so right now we are approximating that there are about plus minus 28 full-time users in our BAHA program, and those who have come back and continued to follow up, continue to rely on us to replace their devices because they eventually do, reach their sell-by date. And as you will see, the technology is also changing and improving. So these full-time users we have been able to keep up to date with. Then the Cochlear Implant program was added to the implant program, and we had our first CI in 2018 with Professor Harris and the rest of the audiology team. I'll touch on the trends of the Cochlear Implant program in the next slide. To date, we have 10 cochlear implant patients that we are following up on. 9 of them are full-time users. The 1 patient is also a user. However, we find that her outcomes are not as successful due to her not using her processor as often as the 9. Continuing with the trends, as I said, the program was developed in 2018. And at the time, the most pressing factors was that in order for us to actually start this program, we needed staff that was trained particularly in CIs. So since then, we have Professor Harris heading the CI implants, or rather cochlear implantation. She's the trained surgeon, and she is also trained a fellow under this program. And then of the audiology team, we have 3 CI trained audiologists. It's not just that team though that we fortunately rely on. We are made up in total of 4 audiologists, 1 ENT, a social worker, and radiologist, and this forms an integral part of the Cochlear team. As I've mentioned, when it comes to technology, of course, we have been fortunate enough to be using for the cochlear implants the latest technology. However, when in terms of the bone-anchored hearing devices, we have moved into or moved away from what we typically known as the percutaneous implant to more of a transcutaneous option that leaves the skin intact and allows for better post-operative care for the patient, which means the skin heals quicker and the patient's able to use their device sooner, as opposed to our bone-anchored hearing devices where our patients would typically have their switch on 3 months after their surgery. So although we don't yet have an actual bone bridge user, we are expecting to have our first 3 patients in June. And then the question of funding. Now, this has been the bone of contention for our program. all of us will attest to that it has been a challenge and a hurdle. And we continue to discuss the ways in which we can allow for sustainability of our program by discussing fundraising options and workshopping ideas that allow for us to attract some sort of funding that will secure more devices in the future for our patients. But I think the question of funding right now lies solely on the fact that it's just a donation-based program. And so it is important, and I will stress that later on in our protocols and in our candidacy criteria, that we actually intentionally choose patients who are able to sustain their devices, to understand that it's important they are responsible for it financially and otherwise. And then our core values. Now, this program seems to kind of sometimes have grown its own arms and legs. And so it's important for us to pause and to think about the values we want to uphold and how we select these candidates, and what we anchor in throughout the management process. So here, these are the values. It seemed very appropriate, since we are dealing with the sense of hearing, to use that as our guide. So our values are heed, empathize, appreciate, and respond. And I won't go through them for too long, but basically when we say heed, because we want to stop and pause and listen to patient stories. Often that actually helps us know the patient better, and along the process we can anticipate what this patient's reasons for wanting to go ahead with a device that is going to help them hear better. So we listen to the patient's stories, we pay attention to the dynamics that inform this patient's life beyond their hearing. Empathize, this is an invaluable tool because, as I've mentioned, it gives insight into the patient's experiences. And so throughout that process, that will help us to, again, anticipate their concerns and to understand their expectations. Appreciate, basically, here I think it's a matter of realizing that although we're using these guidelines at an international and a South African standard, we still want to know that each patient is different from the next. So we use this value often to separate patients from the next and be able to treat them or tailor-make their experience to their own needs. And then finally, once we've heeded, empathize, and appreciate, then we can say we can confidently respond. And responding is what we will touch on in terms of our protocols, in terms of our referral criteria. So finally, what we are all here for, the protocols for bone-anchored hearing devices. And I'll just first start here. As we know, an audiological assessment is our first point of call, and that is usually in conjunction with the medical assessment. So at Candidacy, our clinic works in unison with the ENT clinic. When a patient comes here, we want them to see ENT and audiology on the same day. So we would typically use that from the first encounter with the patient to assess if they are a candidate for a bone-anchored hearing device. What we've borrowed from the Cochlear Implant program is this importance of having a BAHA interview. Now, it might sound very formal when we say interview, but basically use this as an opportunity to get an in-depth case history from the patient, including previous interventions. So often patients, and you'll see later on in that case, I've included that patients have had sometimes previous assessments. I mean, our population is 13 years and older. So if it's a patient who is a teenager, it could possibly be a patient that's been seen at previous hospitals prior to coming to us. So we use this in-depth case discussion to gather that information. We gather their expectations and their concerns. We also use this as an opportunity to get informed consent from the patient for us to share their information on platforms such as the one we are on now, in our monthly meetings that we have amongst ourselves within the department, along with Professor Harris every month. So this is part of the POPI Act as well. So we're trying to heed to that. And then when the patient has met us and we have gathered their information, typically we will give them the options that they have. And before they choose these options, they are likely going to have to do a trial on a bone anchored device. So that would be the next step that we would use. We would ask the patient to go through a bone anchored hearing aid trial where they wear it around a soft band for a month. And then they come back and they inform us of their experience. And that also imparts the responsibility on them to know if they want to go ahead with this. It's a decision they need to make. So that soft band trial is an opportunity to do that. If patients have single-sided deafness, we would typically discuss the transcranial option, or to the transcranial hearing aid first as an option, before we go for a more invasive option like a bone anchored hearing aid. And they can decide if they want one or the other, right? And then radiological assessments, those are important. Scans assess the integrity and the anatomy of the middle ear. And then any other additional specialized assessments such as psychologists, vestibular assessments, social work and educator, we will make those referrals where it is appropriate and where it is necessary. For the cochlear implant protocol, now the cochlear implant protocol is informed by the South African cochlear implant guidelines. And so we've used those guidelines to form our protocol and to be aware of what assessments are necessary before we select a candidate. Again, audiological assessment, all the tests that are necessary, objective and behavioral, for cochlear implant patients. And then we would move on to making an appointment for the patient to have amplification. These patients sometimes have not been previously fitted. They may have been hearing aid user previously, but if the patient was a first-time user or was firstly seen with us, then we would have to go through at least a 3-month trial where they use a hearing aid. This has not included patients who have meningitis and where we know they may be compromised and the cochlea may ossify. So those patients are expedited, but patients where we want to see if they are receiving any benefit from a hearing aid would typically go through a 3-month trial, and along with that, attend oral rehab, at least have 2 pre-assessments during the use with the hearing aids. And then a CI interview. Again, that's the opportunity to get in-depth information about the patient, the support structure, their schooling, whether they use spoken language or they are signing, previous interventions, and expectations, concerns, and motivations are gathered here at the interview. This is often an hour-long conversation with the team, with the patient, building a rapport with them, because we need to help them understand that this is a lifelong commitment, as it is for the bone-anchored hearing aids. But unlike the bone-anchored hearing aid, as you've seen, patients have the liberty to remove an abutment when they want to. That's very different from cochlear implants. Once we choose that patient, we need to ensure that there's never going to be a time where they no longer want to use the cochlear implant. It's a lifetime commitment. So it's important that we use the CI interview as an invaluable tool in our selection criteria. Medical assessments, a full medical workup that's facilitated by the ENT surgeon, and to assess if the patient is fit for surgery here would be included, manage any middle ear infections, and the patient would be informed by the ENT surgeon of the associated risks for pre and post implantation. They would also have to go through blood tests, and if you need more information on how to manage patients who are HIV positive, the South African Cochlear Implant Guidelines are also the greatest resource to refer to, especially within the South African context. And then finally, if a patient has been then selected as a candidate and they have also agreed to go ahead with the implantation, then they would have to get a pneumovac 2 weeks at least prior to surgery. And I think 3 weeks, Prof could clarify this for me, but I think 3 weeks, if they don't get the pneumovac pre-surgery, they can get it 3 weeks after the surgery. But that's part of the protocol for post or rather pre-assessment. And then some self-assessment scales that we would typically ask the patient to fill in. This is to get a better insight of their disability, how it affects them at home, at work, how they deal with it, how they're managing using a hearing aid, and why obviously a cochlear implant would make the world of a difference for them in these environments. And then radiological assessment, very important to know the structure again of the cochlear implant, if there is an auditory nerve. So we would have a CT scan and an MRI included in that. And then additional assessments, again, vestibular assessments are very important for patients who either have reported a history of dizziness or patients who have asymmetrical hearing loss, because when we are deciding on which ear to implant, these vestibular assessments often give us clarity on that. And then social work, our social worker is part of our dedicated cochlear implant team. So she sees every patient to see their financial support. Our patients come from different walks of life, and under the South African socioeconomic stance, we need to know who's supporting them. How are they going to be able to maintain their device? Is this something that is going to add as a burden to them, of which that is not our aim? So we need to know if it's not going to be a financial strain, and is there any other support structure that they rely on other than themselves? And then educators, if these patients are still school going, or they are at university, or they are at a tertiary level, we would include our educators in this process to get more information on their progress at school. And then a speech therapy assessment. This is not always necessary in our candidacy criteria. However, we do refer to speech therapy where it's needed, and then genetics if there is any concern of congenital hearing loss patients, then we would refer to genetics. Often not necessary as well, since we only see adult population. Okay, so moving on to the candidacy and the referral criteria. Now I'm going to start with the bone-anchored and bone bridge candidacy and referral criteria first. And I'm just going to quickly skim through this because I feel that we're a bit more familiar now that our bone-anchored hearing devices are typically for bilateral conductive mixed hearing losses. And with us, we only see, as we've said, children who are 13 years and older, and we prioritize children often. So if it's a unilateral or bilateral conductive hearing loss in children, we will consider them for an implant. But if it's an adult, we need our adults to have bilateral conductive or mixed hearing loss for them to be considered for a bone bridge. In cases where it's a unilateral hearing loss, it will be discussed. It's not to say we don't consider them, but if there is a less invasive option like a hearing aid, and there aren't any malformations, any chronically discharging ears or skin conditions, then the patient would typically be considered for a hearing aid first. For a patient to be a candidate for a bone bridge or a bone anchored device, the bone conduction thresholds need to not exceed 45 decibels. They need to also have a very stable audiogram. So to ensure, and this is one of the indications for bone bridge by the Medal company. So we've been advised by them in selecting these candidates. There needs to be a stable audiogram that hasn't fluctuated at least 15 decibels over 2 years. And if a patient has an unstable audiogram, we have decided that it would be best to rather monitor them over 6 to 12 months. And if there is any need to include medical intervention, to do that along with the monitoring with audiological assessments. And then to make sure that there aren't, of course, any retrocochlear pathologies suspected in selecting these patients. And then we have refined the referral form, mostly because the previous one only focused necessarily on just having the audiogram filled in. But I think the ENTs maybe might attest to this, that it's maybe simpler to go with this option where you, using the guidelines, using the candidacy criteria that I've just discussed, you select patients who are either conductive mixed or SSD and have a hearing loss that is stable. And if it's a temporary hearing loss, we need to rather know that this patient is not yet a candidate. So you wouldn't go ahead with referring them. However, there are cases where the hearing loss is permanent, but it's unstable. So that would be necessary to just note. And then here I've also included to just mention if the patient has used conventional hearing aids, are they not receiving any benefit from them? And if there's an option to go with that route, then rather we consider that instead. And then right there's if there is a middle ear pathology, is it treatable? That is important for us to decide for these candidates. And if you are considering a bone bridge on Baha or transcranial, we'd just like you to indicate exactly why and why you think maybe the patient would benefit from either one of those devices. Okay, now for cochlear implants, once again, that's our population, 13 years and older, and all adults of any age. The degree and type of hearing loss for patients who are considered for cochlear implantation have to have a bilateral severe to profound sensorineural hearing loss, with speech recognition scores being one of the main indicators of their use for or their need for a cochlear implant. So that being using the psychic guidelines, that being that the poorer ear has to be 60%. Sorry, let me just say this again. The poorer ear needs to obtain 60% at 40 decibels in the best aided conditions. We would typically have a full CI assessment where patients who are using hearing aids would be assessed, and we would want to know why it is that the patient would be considered for a cochlear implant. And so moving on, age of onset, for prelingually deaf patients, they need to be using spoken language as a primary mode of communication. Duration of hearing aid use, have to be using hearing aids. This is important because this informs the outcomes of a cochlear implant. Early intervention and full-time use of a hearing aid should be, the patient, just give me a second. Early intervention, yeah. So early intervention is very important because we typically do get referred patients who have been using implants, or rather hearing aids, for long periods of time. Our latest cochlear implant candidate is a 33-year-old patient who had congenital deafness that had been fitted with hearing aids at 1 year old. Now, this patient has spoken language. So although they are prelingually deaf, we are certain that their outcomes with the cochlear implant are likely to be much stronger than that of a patient who has been rather prelingually deafened and rather used sign language as their primary mode of communication. That would speak to whether or not the cochlea or the auditory nerve is aware of speech, and that is likely going to make sure that the patient has better outcomes when they are using the cochlear implant. So if this patient prefers to be that of a sign language community, we have had patients tape a great cochlear and you get okay. Apologies about that. I'm hoping you can all hear me. We just got kicked out. Divya,
Yes,
if you can.
yes, we can hear you.
Okay. So I was just touching on, I hope you, I'm not sure at which point we lost connection, but we're just touching on the importance of hearing aid use and spoken language as a main criteria for selecting patients. We have had candidates that seem to be great on paper, may have full-time use of their hearing aid because at the point that we see them, they're using a hearing aid. However, in the case history, or in the cochlear implant interview, where we first meet the patient and where we often ask patients to be accompanied by a family member, we notice that upon further insight, the patient is using sign language as their mode of communication. So that speaks to whether or not the patient will be likely committed to using their device once they get a cochlear implant. And it also speaks to their awareness of speech, whether or not the auditory nerve has been having full-time exposure to speech and to sound would be very important for the best outcomes. So it is quite important to stress that those patients need to have spoken language as their main mode of communication. And then moving on to medical and radiological findings, as I've discussed before, that patient will be seen along with audiology and likely assessed by the ENT if they are fit for surgery. And some of the contraindications would be heart disease. If a patient is HIV positive, they have to have an undetectable viral load. Mostly important is that there has to be a present auditory nerve. Apologies there, that's the word that's supposed to follow after auditory. And then the cochlea must be patent on the scans. And of course, there shouldn't be any active middle ear condition. And then finally, in terms of vestibular assessment, as I'd mentioned before, in cases where patients have a unilateral vestibular hypofunction, and we see this often with asymmetrical hearing losses, or patients who have one hearing aid use, or one ear using a hearing aid, it could be that is the ear where they have the best vestibular function, meaning the ear where they're not using any hearing aid is the unilateral vestibular hypofunction. So we have to decide what best ear to implant based on that and based on the recommendation made by the audiologist at the Dizzy clinic. And I've just included one of the resources that you'll see if you log on to the SACIC guidelines website. This is quite a nice article that discusses the evolving criteria of adult and pediatric cochlear implantation. And I found this article interesting in the sense that it does discuss that there used to be quite a stringent selection criteria that was followed, and as the advancements of technology and the market providing different electrodes, then you become more the options to choosing cochlear implantation candidates becomes much more wider based on the advancements of these technologies, especially electrodes. So I think that would be quite valuable to just go through, and you will find this on the SACIC guideline websites. So once you feel that a patient may be a great candidate, we would like you to fill in this referral form. It does just touch on the patient's details. You will usually have this in the folder, but you have to confirm if the folder's information coincides with what the patient's existing information is. And often our patients likely have been coming to the hospital for many years. So it would be likely that those details could have changed. Please confirm if they are the same or if they've changed. And then the support structure, of course, of which we go into detail with in the CI interview. Communication occupation, that speaks to how we've mentioned previously the importance of an oral versus sign language communicator, to ensure that you indicate which of those mode of communication the patient is using. If the patient is employed or unemployed or on a DG, it's not to say that they're not a strong candidate, but as we've mentioned, their financial standing, their financial support does speak to their capability to maintain and be responsible for their implant in the future. And then the onset of hearing loss, please give very ear-specific information that will also inform knowing which ear is likely going to be implantable should they be a candidate at our final discussion. And then I don't have to discuss the rest. We're all familiar with that. Information about dizziness, noise exposure, any medication that they may be on, and the medical contraindications to surgery. Now, the implant team, all these assessments aren't, of course, done by one professional. The implant team consists of audiologists, ENT, radiologists, social worker, and additional specialists. I've highlighted the main professionals that are involved in selecting candidates and assessing for them, and the additional specialists from our perspectives. And this is how we see ourselves when we are dealing with patients. We see ourselves isolated from each other, likely, and in our own capacity doing the assessments that we need to. However, maybe we should start to consider that this is likely how we look from the perspective of the candidate. This is important, likely, to think of ourselves as not just working in isolation, working in silos, but working together as a team, having a shared vision, having a shared cause in terms of making it a point to intentionally choose patients who are going to have the best outcomes should they be cochlear implant or bone bridge candidates. And then finally, this is the case that was brought to us about a month ago. I will protect the patient's identity just to give them the initials. LB's case, who's a 34-year-old lady who I saw for an assessment, and she was referred by Tygerberg. Now, LB has had a hearing loss since she was a child. She presented with speech delays at 3 years old and subsequently was diagnosed with bilateral conductive hearing loss at Red Cross. She's attended Vita Boma School for the Deaf at 4 years and was fitted with the Baha steel band on the left ear. She's been using a Divino, or rather used a Divino, a processor that's from Cochlear, on an abutment in the left ear, but it stopped working in 2017. And she's been struggling with communicating ever since. And, you know, when I saw her, that was one of the main concerns that she had, that she doesn't actually even leave her house because she's just afraid that she's going to be in very challenging communication environments. And even though she wants to socialize, her hearing loss makes that very hard. She hasn't been able to replace her Baha because of financial constraints. They were used to be on a medical aid, and since then, when the breadwinner of their family was no longer able to support them, they had to be taken off the medical aid. So that made things quite hard to then follow up and get another processor replaced. She has trigeminal nerve paralysis from the complications of the Baha and the adenectomy surgery. And she currently presents with right facial nerve paralysis. She could hear very well with the Divino, although she did mention that she was quite concerned about how it looked in terms of aesthetics and the cosmetic appearance of it. And then she then decided to refer herself for a cochlear implant to the Tygerberg unit. She's now currently unemployed. She holds a diploma in business admin, and she uses oral communication in English, and she's very fluent in South African Sign Language. But however, even though she's an oral communicator, she still relies heavily on lip reading, where she struggles, obviously, then in group situations where she can't follow every conversation. She's unable to use the phone. Now, she was seen at Tygerberg, and the features initially looked like, based on the audiology, that she had Treacher-Collins syndrome, but it has never been formally diagnosed. There is an abutment that is still lodged into her skin on the left. However, upon examination, it looks quite flush and it's not protruding at least 3 millimeters. I've got a few audiograms that I'd like to include here as well. Some of the symptoms that she also mentioned was, or rather she didn't mention of any fluctuating tinnitus and no issues with balance or dizziness. So she has very narrow ear canals, and these are her audiograms from Helen Joseph in 2018, when her family was still residing in Johannesburg. That is where the operation was done for the abutment. And then she was seen at Tygerberg recently, and that is her hearing test from Tygerberg. You can see that the right ear is presenting as a dead ear with no responses across all frequencies. And then she has a severe, profound hearing loss in the left ear, or rather severe hearing loss in the left ear. And then when I saw her, these were her audiological results. And this was the most recent audiogram that I obtained. So this is how this case presents, and I'd like us to just consider what would be maybe the relevant clinical information you would like to know, or that you would like to further obtain for this patient. If anyone is interested in chatting about that, could you just please provide us with your suggestions?
As I understand, she was able to, she does speak English, but for the past few years, because of the fact that she couldn't get her Baha to function back again, she's been using sign language.
Yes. Well, I mean, she uses sign language, I think, as an option because she was I would say socialized with people who use sign language, but with her family, they are very much spoken language. They all communicate with they all communicate using spoken language. Her mom mentioned that her family, her sisters and her brothers use sign language with her. However, she does not know sign language, the mom, so they only use oral communication.
Hlomi, if I can just ask, what is the speech like? Because I think that would be an indication as to what kind of access to sound she's had as a child. Does she just deaf speech, or is
no, she has very clear speech. I think more I observed that she had more of a slur because of the facial nerve paralysis. So her lip is drooping to the left, but other than that, I can hear her clearly. And I was able to do speech tests, word identification tests that she scored quite well on. If you can see, I don't know if you can see clearly the speech scores on my audiogram. Is this able to zoom in? But I have there at 90 decibels, she's scoring 95% in the right ear, and at 90 decibels in the left, she's scoring 95 as well.
Yeah. And do you know what her use is like when you sort of look at a processor, whether she was using it consistently?
So the processor now is malfunctioned, so she doesn't have one anymore. But she did say that she used it and relied on it. So we only can rely on her report. Yeah. that I can't speak about the processor because it wasn't something that she had with her anymore. She hasn't had it since 2017.
Yeah, I'm a bit confused as to why there's such a big discrepancy between the previous audiogram at the other hospital and this one. How do you account for that?
Yeah, if you see, my audiogram is very similar to the audiogram from Helen Joseph. So it's I mean, the right ear is slightly better in Helen Joseph, but there's not too much of a discrepancy. So I'm not sure if that was I don't know, maybe the what is it, the equipment, but I wasn't expecting to get those results for the right ear because I expected that right ear to be a dead ear.
Yeah, and do the tuning fork tests, I don't know if she's been seen by ENT, by us, but.
Okay, so Prof, one of your assessments would be tuning fork. You haven't seen her, no. She hasn't been seen.
The tuning fork testing doesn't confirm the findings of that audiogram.
So you haven't seen her yet. So that could really maybe make it clear on what's happening in terms of the right and the left ear. But she has been referred to ENT.
Wouldn't she need imaging? Yeah, she definitely needs Yeah, she definitely need imaging. Yeah, Matt's just saying that she'll need imaging, which is yeah, she'll definitely need imaging. But I was just looking at, and that looks like I'll just go back to that audiogram.
Okay.
You see, I'm a bit concerned about the size of that earbone gap, which is and it's not that it's not masked either. I mean, did you have a masking dilemma when you tested her?
I did have a masking dilemma, but Sharon would like to say something.
Okay, Tasneem, I also questioned that, but just looking at the pure tone results. But because my first impression was that maybe it should have, not the bone conduction, but the air conduction needed to be masked because of the earbone gap. But if you look at the speech was masked. So that gives you a greater indication that that could be correct.
Can you hear Sharon? Hello?
It's connected to your TV.
How do you disconnect?
Can you guys still hear us?
No.
No access.
I'm not muted. Can you still hear us? Oh, I think they could chat.
Sorry, someone just we're trying to get back.
But you can hear us, eh?
Yeah,
now we
we
can,
can. Sorry,
yeah.
that's
Oh,
disconnected.
okay.
So Sharon, you were saying?
Okay, I was saying that when I looked at the pure tones, I also straight away thought that should you mask, because of the big airbone gap, if you masked the left ear, you probably would also get a dead ear. But then I looked again at the speech results, and the speech results are masked, which means that doesn't stand true. So as the audiogram stands, maybe the bone on the right ear could be a little bit less, but it's a functioning ear.
Yeah, absolutely. I mean, I think if you do look at that speech, if you look at the speech audiogram, then you can see that it can't be a dead ear, absolutely. But I'm just wondering about I think one of those bone conduction thresholds must be a bit lower than they actually are, because those are very, very big airbone gaps.
Yeah, the biggest and I didn't note this, but the biggest issue was that when I masked, it would over mask her opposite ear. So that's why those BC thresholds stayed unmasked. So if you add masking to either one of those ear, you get about 90 decibels of masking, which is too much masking. And that essentially then doesn't allow for her to hear the BC thresholds well. And eventually you just get a masking dilemma because you also can't reach a plateau. So that is why the BC thresholds are unmasked.
Yeah. And then Matt also just suggested a CT scan in terms of clinical information because she's got a syndrome. We also want to assess for any other abnormalities and the position of the facial nerve. I wonder with it could be with the Baha. It might have been a very aberrant nerve. I'm not sure where the Baha was inserted.
What's the concern about the fifth nerve fallout?
Yes, and as Prof. Sagan says, the fifth nerve fallout doesn't quite fit in. Even with those procedures, you shouldn't get a fifth nerve fallout.
Sorry, say that again, the last part.
You won't get a trigeminal nerve fallout following Baha and an adenoidectomy. Makes sense. So I mean, probably an MRI as well.
Okay.
Yeah.
Great. And once these assessments then have been done, what implant device would you recommend for this patient? And could you explain maybe why?
Well, the thing is, she's had a bone anchor device, hasn't she? I'm just wondering. So, just on the history, you're saying she's had a bone anchor device that was working at some point. Did she have benefit from that?
She did. She did. From her own reports of using the device, she said it did work for her quite well. I don't think that the only thing she mentioned was her not liking the cosmetic appearance of it.
Yeah, because just looking at her audiogram, she would be a good person for a bone conduction device. But I think the biggest thing is probably compliance. And the fact that she still occasionally uses sign language as a mode of communication, when actually with those thresholds with a bone conduction device, she shouldn't need to use any sign language at all.
Yeah.
So one, either she's not actually getting any benefit, and then one has to investigate why, or two, she's just not a very compliant user. I'd actually question that, because I'm just wondering, it doesn't make any sense. With those thresholds, you should be functioning almost as normal when you look at
Exactly.
a speech.
Yeah, and what do you think about the fact that the processor actually has not been working for 5 years and she hasn't sought, or at least it seems that she hasn't sought any intervention since then?
Yeah, also, once again, that would be a red flag for me. I mean, this is an expensive device. If I was that dependent on a device to function every single day and it had that much benefit, I wouldn't wait 5 years before seeking help, if you know what I mean. When you come into a state service like this and we have limited implants, then you really, really have to look into one patient's insight and their motivation. Because it's not like you can just decide one day, this is okay for me, and the next day, actually, I don't like this anymore. I mean, as you know, we've got one for every patient who needs it. So that is a really big red flag to me. I really want to go and question. I'm not saying you shouldn't get it, but we really have to go and question her and ask for why. Because I think, and this has come up time and time again, this was for young girl, and often when they go through, and this has been shown, patients like they kind of go through adolescence and puberty, and I've had patients like that myself, they end up with a speech processor in the pocket. They have access to the device, but they don't use it because of the cosmetic concerns. And she was kind of going through that time where exactly that, body image is important, and, maybe she's a little bit more, she's trying to change her mind about things, but it is something that we have to explore, and that's one of the problems with adolescent patients, the ones coming across from Red Cross or from private who may have had bone devices before, or have got conductive hearing losses and are candidates for bone anchored devices, is that they often are not using it mainly because of cosmetic appearance issues. I think it should be someone that I would want to really interview, just to see, one, how much insight she has, and actually also her motivation.
100%, yeah.
Either way, she still kind of needs the scan.
Okay. Okay, do you think those hearing tests need to be done again? Would anyone suggest that? For a more stable, because one of the concerns maybe would be this instability of her audiogram. I mean, the audiograms weren't far apart from the one in Tygerberg that was on the 1st of March, and this one was on the 4th of May.
Can you show us the speech scores of the one that was done at Helen Joseph? Do they have speech scores there?
Yes. Helen Joseph. But let me just grab the folder because it is here.
Yeah.
Where is it? Oh, okay. Can you see my mouse? Rather my there.
Yeah. 100%, 90, 85%.
Can't read from here.
The right 30% unmarked without noise, and 77%. So it was, and 93 on the left.
Yeah, so it's very similar to ours. Yeah.
It's quite different in the sense that she did not mask. Firstly, for the higher thresholds, and she got way poorer results at 85 than she was getting with ours, because she scored 95% at 90 decibels for both ears. Here she scored at the highest threshold, she scored 87% at 100 decibels.
Yeah, I would repeat the audiogram here in about 6 months' time, and then
Okay.
maybe call her in for an interview so we can see, where she's at and what her motivation is, what her compliance was like. I mean, here's the thing: if you've lost your processor or it's not working, and you're waiting 5 years before you come back, and you've not gone, seeked help. I'm just questioning whether or not, if she were a candidate for a bone anchor device from our institution, what her compliance is going to be like here. I mean, our patients, if there's ever an issue, they come back immediately. They don't wait 5 years. But that's because we've got a very strict screening process as to how we kind of screen them before they become before they're recipients of the bone devices.
Okay. So, is that fine? Thank you very much, Prof. Is there anyone else who'd like to add anything?
Sorry, I was wondering on the Tygerberg audiogram, I see that they did do a tuning fork, but it was a negative bilaterally. Could you still get that if the right ear was a dead ear? That just be on the other side.
Hlomi,
Oh, yes.
this is a question from someone on the talk. Hassan Dadi wants to know, patients with unilateral profound hearing loss, are they considered as candidates for CI in our protocols? Maybe I can answer that, if that's okay.
Sure.
Yeah, Hassan, not in the state sector with limited implants. I think even in the private sector, not all of the medical aids would approve unilateral hearing loss in this country. I know it is in the States, but I think in the States, in the South African setting for now, medical aids are not going to approve it. The only way you can get your implant if you've got unilateral hearing loss is if you pay for it yourself, but the medical aids won't fund it, and definitely not in the state sector. No.
Okay. Okay. Thank you, Tashnim.
Okay.
Can I just ask a clarification on one of the criteria for the implant? You said the Hlomi on the table, you mentioned about unilateral hyperfunctioning, vestibular hyperfunctioning. It is on the weak ear. You implant the weak ear. You're talking about the hearing, the weaker hearing ear, or the ear that's got the unilateral vestibular hyperfunctioning?
When it's bilateral hearing loss,
Yeah.
and the patient doesn't benefit, you're going to implant. So it's quite tricky because that's why we have an interview, right? Because you want to implant the ear that has had access to sound for longer.
Yeah.
Yeah.
But then at the same time, you need to make a decision as to if you implant a patient who's got bilateral hearing loss, which ear is the better, which is the worst ear in terms of vestibular function. So if you have 2 ears, then you have to choose.
Yeah.
Because you can choose either left or right. Then you're going to base that decision on your vestibular function tests.
Okay.
And you're always going to implant the weaker one because you don't want to compromise the vestibular function.
Yes. Okay.
Having said that, you also have to look at other factors like where have they been wearing the hearing aid the longest? Is that the ear that's, so if we have to make that choice and you are implanting the better vestibular function ear, and you anticipate there's going to be a problem, then you know we have to send it to vestibular rehab.
Okay.
And then you also have to take into account access. As a surgical access, so we look at the scans, it's a whole bunch of things that and I think it might be nice if you can't, if you are rotating through the otology, if you sit in on our candidacy meetings, because then you get a clearer picture of exactly what it is that we kind of look at. It's not just audiology. It's a whole bunch of things, and we obviously have to adapt the criteria to our setting because we've got limited implants and funding, and we want to make sure that the patients that we implant are going to get the best outcome.
Would you delay cochlear implant for patients who are partially compensated? Would you wait for them to first go to the vestibular rehab?
We always send it to the vestibular rehab.
Yeah. Check again.
Yeah. Yeah.
Okay.
Hello.
I don't think there are any other questions.
No other questions.
Okay.
Thank you very much.
Thank you very much.
We haven't finished quite, but that is the end of the presentation. However, we'd like to just share a video of a patient who has just recently been switched on. They were switched on this year for their cochlear implant. This patient has had a hearing loss, a profound hearing loss bilaterally for 3 years. They suffered a sudden hearing loss after a sudden illness, and that was quite hard for them because then they had to stop working, and unfortunately that led to them kind of, trying, or rather kind of giving up. So you'll see how different this patient is in this video and how hopeful they are. And we just wanted to see what example it can be for someone who had no hope and now does. how these implants can actually change their life. So I'm just going to share this. Shaz, can you give me a hand here? And pop here. Yeah.
Sorry, we can't hear. Is there sound to the
Hlomi, is
video?
there sound?
Can you hear me?
I
Yeah.
hear you, but is there sound in the video?
Okay. Okay, and just start it again. Pull it. And then play it. Do you hear anything?
No.
No.
Switch on the cochlear implant.
We're not sure as to why there's no sound.
Probably it's playing on your speaker.
Probably if it enables something.
Say that again, Divya.
Maybe it's playing on your.
Let's
Rather-
see. See if
Say the word Thursday.
Thursday.
I was. Say the word Wednesday.
Yeah, now it's Wednesday.
Say the word Friday.
Friday.
Wow. Say the word Saturday.
Saturday.
Say the word Thursday.
Thursday.
Say the word Thursday.
Thursday.
I was tricking you there, just making sure you're not using your brain. Okay, Tarai, that was amazing. That was 100%.
We've never had that.
Yes, I
Wow.
am almost 100%.
Almost 100%.
I think in 1 week time I will be 100 and something %, which is not abnormal.
okay, that's it. Thank you so much. That's the end of it. Thank you for giving us this time and for just sharing with us your educational space. We hope that this was helpful in any way.
Yes,
Thank you very
absolutely.
much,
We learned
Hlomi.
a
That
lot.
was very nice.
Thank you, Lisa.
Thank you
All
so
right.
much. Okay,
Bye.
bye.